Welcome to the StudyNeuro neurosurgical teaching series. Today, we'll be discussing the principles of application of the Mayfield Head Holder, a cornerstone tool in modern neurosurgery. The Mayfield Head Holder is a 3-pin skull clamp system designed to provide rigid cranial fixation. It was introduced in 1973 by Dr. Frank Mayfield, who sought to improve upon the older horseshoe headrests and less stable fixation methods. Its mechanism is straightforward but powerful. 3 pins anchor into the outer table of the skull, creating absolute immobility. This stability is crucial because it minimizes head movement, maintains precise positioning, and allows surgeons to perform microsurgical, endoscopic, stereotactic, and functional procedures with maximum safety and accuracy. In practice, it has a wide range of applications, from supratentorial and infratentorial craniotomies to spinal procedures in the prone or sitting positions, to endoscopic and stereotactic interventions such as deep brain stimulation and biopsies. It is even applied in frameless radiosurgery for precise radiation therapy positioning. This lecture will walk through its safe and effective use, highlighting the principles that ensure both patient safety and surgical precision. Now let's take an overview of the main components of the Mayfield system. The device can be understood in 3 main groups of parts. First is the base unit, which anchors the system securely to the operating table. This is the foundation, ensuring that no patient movement is transmitted to the surgical field. Next is the articulating arm. This connects the base to the head fixation device. It provides rigid fixation while allowing controlled adjustments. By fine-tuning the arm, the surgeon can achieve precise head positioning and maintain stability throughout the procedure. Finally, we have the head clamp, or horseshoe attachment. The clamp uses pins for rigid cranial fixation, while the horseshoe attachment provides non-invasive support. The latter is especially useful in pediatric patients or those with fragile skulls, where pin fixation may not be safe. So together, these 3 groups, the base unit, the articulating arm, and the head clamp, work in sequence to deliver stability, precision, and safety during neurosurgery. Before applying the Mayfield Head Holder, preparation is absolutely critical for both safety and effectiveness. The first step is to assemble the device and confirm its stability. Every screw, joint, and locking mechanism must be checked to ensure that nothing is loose or faulty, because even a small instability can compromise surgical precision. Next, a thorough preoperative skull assessment should be performed. Imaging, such as CT scans or bone density studies, help identify weak areas, previous craniotomy sites, or defects that may not be suitable for pin placement. Knowledge of scalp and skull anatomy is essential. We must deliberately avoid regions with thin bone, areas overlying neurovascular structures, and any prior surgical modifications that could weaken fixation. The patient's head is then carefully inspected. We look for scalp infections, scars, or evidence of bone weakness at potential pin sites. Patient selection also plays a major role. In adults with sufficient skull thickness, pin fixation is appropriate. In contrast, for children, infants, or patients with thin or fragile skulls, cushioned pads should be used instead of pins to reduce the risk of injury. Once the fixation method is chosen, the surgeon must determine the optimal surgical position, whether supine, prone, lateral, or sitting, depending on the procedure and exposure required. Finally, strict sterile technique must be observed throughout the process, and pins should never be placed in neurovascular danger zones, such as the temporal fossa, where injury to vessels, nerves, or thin bone can occur. In summary, careful preparation, device check, anatomical assessment, patient selection, positioning, and sterile practice lays the foundation for safe and effective application of the Mayfield Head Holder. Once preparation is complete, the next critical step in the application of the Mayfield Head Holder is proper positioning. The choice of position depends largely on the planned surgical approach. The most common positions are supine, prone, lateral, or sitting. Each has its advantages and is tailored to provide the best exposure for the specific pathology being treated. While positioning, we must always prioritize anesthesia and airway safety. Rigid head fixation can limit access to the airway, so it is essential to ensure that the endotracheal tube is secure and that the anesthesiologist is comfortable before pins are applied. Ventilator tubing should be carefully arranged and secured to avoid accidental displacement once fixation is complete. Another key principle is maintaining neutral cervical alignment. Excessive flexion, extension, or rotation of the neck can compromise venous return, restrict the airway, or cause cervical spine injury. Therefore, adjustments should be deliberate and carefully observed. Cosmetic considerations and the surgical approach must also guide pin placement. For example, when operating near the forehead, surgeons may avoid placing pins in visible areas to reduce postoperative scarring, or they may choose alternate pin sites if the planned craniotomy would interfere with the fixation points. In summary, positioning is not just about exposure. It is about balancing surgical access with patient safety, airway security, cervical protection, and long-term cosmetic outcomes. Pin placement is one of the most critical steps in the safe application of the Mayfield Head Holder. The system works on the principle of three-point fixation, often described with the soccer ball concept. 2 pins are placed below and 1 pin above in a way that supports the skull like a sphere resting securely from underneath. This arrangement provides anti-gravity support and reduces the risk of slippage. Pins should always be positioned on thicker parts of the skull, particularly above the linea temporalis, where bone density is greatest. At the same time, we must avoid danger zones, the thin temporal bone, cranial sutures, areas of prior burr holes or shunt sites, and skull fractures. Pin placement over these areas risks penetration, instability, or even intracranial injury. Because pin insertion is a painful stimulus, it requires careful coordination with anesthesia. The anesthesiologist should administer a bolus of analgesia, and in some cases, local infiltration at the pin sites is added for additional comfort and safety. Technique is equally important. Pins must be applied perpendicular to the skull surface. This prevents skiving, where the pin slips tangentially rather than gripping firmly. Pressure is adjusted to the patient's age and skull thickness. Adults tolerate more force, while children and patients with thin skulls require lighter settings. Tightening is done gradually and symmetrically using the nail-jacking handwheel so that pressure is distributed evenly across all pins. The goal is to firmly engage only the external table of the skull, without penetrating deeper into the diploe or inner table. Finally, in pediatric patients, special caution is required. Unfused sutures must be avoided, and imaging or careful palpation should be used to confirm safe bone zones before placement. In some cases, cushioned pads may be safer than pins to prevent fractures or brain injury. In short, safe pin placement demands anatomical knowledge, gentle technique, and close teamwork with anesthesia to ensure secure fixation without compromising patient safety. Another key principle in the safe application of the Mayfield Head Holder is the protection of neurovascular structures and venous sinuses. First, let's consider the arterial structures. Pins should never be placed over superficial arteries, such as the temporal or occipital arteries. Injury here can cause significant bleeding, formation of a pseudoaneurysm, and even loss of that vessel for future bypass grafting. If bleeding occurs, it should be managed with deep sutures for hemostasis rather than staples to ensure proper vessel closure. Next, the nerves. Superficial sensory nerves, particularly the supraorbital and supratrochlear nerves in the forehead and the occipital nerves posteriorly, must be carefully avoided. Injury to these nerves can lead to persistent numbness, neuropathic pain, or hypersensitivity, which can severely affect patient quality of life. Equally important is avoiding the venous sinuses. Placing a pin directly overlying a major sinus, like the superior sagittal sinus or transverse sinus, can cause venous injury and result in a venous air embolism, VAE. This complication can be life-threatening, especially if the patient is in a sitting position where negative venous pressure facilitates air entry. To prevent VAE, antiseptic ointment should be applied at the pin sites to act as a sealant. Additionally, if the head holder needs to be removed, it should be done in the supine position, sometimes with positive end expiratory pressure, PEEP, to minimize the risk of air being sucked into venous channels. In summary, safe pin placement is not just about stability, it's about respecting the underlying neurovascular and venous anatomy. By avoiding superficial vessels and nerves, steering clear of venous sinuses, and using preventative measures, we minimize the risk of potentially serious complications. When it comes to the Mayfield head holder, proper force application and stability checks are absolutely critical to both safety and effectiveness. For adults, the recommended tightening force is around marker 3 on the device scale, which corresponds to about 60 pounds or 27 kilograms. This provides sufficient fixation strength without overloading the skull. Importantly, we should never exceed marker 4, roughly 80 pounds or 36 kilograms, because doing so greatly increases the risk of skull fracture, dural laceration, or bone penetration, all of which can lead to serious complications. Once the pins are tightened, a simple but important maneuver is to rotate the hand wheel slightly counterclockwise. This relieves any torsion that might have twisted the scalp during pin advancement, reducing the risk of pressure sores, tissue injury, or skin necrosis. Before proceeding with surgery, a stability check must always be performed. The surgeon should gently rock the patient's head in both the antero-posterior and lateral directions to ensure there is no micromovement. If any instability is detected, adjustments must be made immediately. Finally, all the starburst connectors, the locking interfaces between the articulating arm, base, and clamp, must be secured in a top-down sequence. This ensures that the entire construct is properly locked, aligned, and stable throughout the procedure. In short, achieving stability is a balance, applying the right amount of controlled force, protecting the skin and bone, and meticulously checking every lock. These small but essential steps guarantee that the patient's head remains absolutely immobile, which is the cornerstone of precision in neurosurgery. Now, let us emphasize the key safety principles when applying the Mayfield head holder, because this step is absolutely critical to avoid complications and to ensure reliable fixation during surgery. First, always think about symmetry. The pins must be applied evenly so that pressure is distributed equally across the skull. If one pin is tighter than the others, not only does it risk penetrating too deeply, but it also compromises stability and increases the chance of slippage. Second, use controlled force. Tightening should always be gradual, stepwise, and with feedback, never sudden or forceful. Remember, we are applying mechanical force directly onto the skull, and excessive tightening can cause depressed fractures or skin necrosis. Third, take care to avoid critical structures. Do not place pins over areas of thin cranial bone, such as the squamous temporal bone, over cranial sutures, or directly on planned surgical entry points. This is not only for patient safety, but also to prevent interference with the operative field. Finally, ensure secure locking once fixation is achieved. Every screw, regulator, and locking mechanism must be firmly fastened. Even a small amount of play in the system can translate into head movement during a delicate maneuver, which is unacceptable in neurosurgery. By consistently applying these principles, symmetry, controlled force, safe pin positioning, and secure locking, you create a safe and stable construct that protects the patient and provides the surgeon with confidence throughout the operation. Once the head has been fixed in the Mayfield holder, our responsibility does not end there. The next step is to verify stability before proceeding further. This is done by gently testing the construct, attempting subtle movements in the anteroposterior and lateral directions. A properly applied Mayfield holder will hold the skull absolutely immobile. If any movement is detected, the fixation must be readjusted before draping, because once drapes are in place, access to the system becomes difficult. After confirming stability, it is equally important to maintain vigilance throughout the procedure. Verification of clamp security should not just be a one-time event. Even intraoperatively, if the patient's head position is changed or if there are long durations of surgery, the fixation should be rechecked. We must also stay alert for potential complications. These include skull fractures, especially in pediatric or osteoporotic patients, scalp lacerations or pressure necrosis from excessive pin force, ischemia from compromised local circulation, and gradual pin loosening, which can occur if fixation was suboptimal or if the patient's head was manipulated. Therefore, the guiding principle is fix, verify, and continue vigilance. This ensures that the patient remains safe, the skull remains immobile, and the surgical team can focus entirely on the operative task without unexpected surprises. At the end of surgery, the removal of the Mayfield clamp must be performed with the same care as its application. The key principle is to remove pins in a controlled, safe manner to prevent additional scalp or bone injury. The removal steps are straightforward but must be followed systematically. First, apply gentle pressure on the patient's head against the two remaining pins while you release the single pin. This ensures that the head does not suddenly shift or cause a scrape from an uncontrolled pin release. Always remove the single pin first, as this minimizes the risk of accidental scalp laceration. After the pins are removed, it is good practice to massage the scalp gently around the pin sites. This helps reduce residual impressions, improves local circulation, and promotes faster healing. One common issue after removal is pin site bleeding. Most cases are minor and controlled with simple direct pressure using sterile gauze. However, if bleeding persists, especially in patients with friable skin, anticoagulation, or thin scalp, the technique is to pull the skin edges taut and place a single staple across the puncture. The staple can be removed after 3 to 5 days once the site has sealed. Beyond bleeding, we should remain vigilant for less frequent but important complications, such as scalp infections, delayed healing, or in rare cases, a depressed skull fracture in patients with very thin bone. Careful pin placement, controlled force application, and sterile technique go a long way to preventing these problems. In summary, release safely, control bleeding, and monitor healing. Clamp removal is not just a mechanical step, it is also the start of post-operative pin site care. As we come to the conclusion of this session on the Mayfield Head Holder, let's bring together the core principles. First, preparation. Always start with a thorough preoperative assessment. Evaluate the patient's skull integrity, look at bone density, and carefully select safe pin sites while avoiding thin bone, sutures, or prior defects. Second, precision. This device demands accuracy. Pins should be placed symmetrically, tightened gradually with controlled torque, and the applied force must always be adjusted to the patient's age and skull thickness to avoid complications. Third, safety. Never compromise here. Avoid neurovascular danger zones and venous sinuses. Ensure all screws and regulators are fully locked, and confirm that the construct is completely stable before proceeding with draping and surgery. The take-home message is simple but vital. The Mayfield Head Holder is not just a fixation device. It is a cornerstone of stability, safety, and precision in neurosurgery. Its effectiveness depends entirely on our respect for anatomy, technique, and vigilance throughout its use. Finally, thank you for engaging with this session. For more neurosurgical insights and practical pearls, don't forget to follow at StudyNeuro. And please like, comment, share, and subscribe. Your support helps us keep creating valuable educational content.